Hi, Don here. Welcome to Podiatry Practice Mastery, where we're helping you get your practice to the $1 million mark and beyond. Actually, now it's beyond the $1 million mark, so I want to help you get your practice from about 1 million to 1.5 or 2 million. This is for individual doctor production, so if you have multiple doctors, the goal would for each of them to get there. So that's what we're kind of working on. Today, I'm going to go over my day. This was a full day. I've started to kind of cut out some of the more repetitive things, such as the routine things. I don't think we need to go over that much. But I wanted to tell you, as you know, I've been using a nail tech for quite a while. She's getting much more capable right now. Her name is Marjorie. I use her on Friday, so we do a half day of Friday nail care. And so I'm doing patients, she's doing patients. We found kind of like a happy number for her is every 15 minutes. So she brings them in, sees them, I quickly see them, and then they go out. Now we have a little snafu the other day because one of my partners isn't doing any nail care anymore. So I had my normal patients, and then they were putting her patients in, so 4 per hour, and I was having to see them. It kind of glutted some of the rooms. So what we've figured out on that half day on the Tuesday, where I'm just kind of overseeing her nail care patients, I'm not doing any 10-minute follow-ups. So the way my schedule usually is patients every 20 minutes, and then 2 per hour I have a 10-minute follow-up. So a lot of mine are just quick follow-ups in 10 minutes, but when I'm having her do her patients 4 per hour, then I am not doing that. So this is something that we're kind of perfecting as we're using her. And then we are also probably giving her a raise because she's been here for about a year. And I think she's about 23 an hour, and I think we're going to move her around 25 an hour for this because she's actually a revenue producer. And I'm excited. She's starting to do more of the carry flex for us, which was really a time saver and kind of a revenue producer, and also some Onifix and things like that. Okay, well, main things for the day, patient, a 71-year-old. Actually, I'm going to go over my MVP. My MVP patient was my orthotic patient. This is a patient, 61-year-old female. She had right hallux limitus, and she had left plantar fasciitis. She's status post 6 shockwaves. She's doing much better. And we did an orthotic for her, for both the hallux limitus with the Morton's extension and for the plantar fasciitis, so things don't come back. So this is my one orthotic of the day. If you don't know, I try to get 2 orthotics a day, so by doing 2 a day, I'd be able to get to the 40 mark per month is where I'm wanting to get. Next patient I'll talk about is a 71-year-old female. She had shockwave number 4 out of 6 for her plantar fasciitis. She's starting to feel better. Next was a 58-year-old man. He was here for Swift number 4. He has a really big wart on the back of his heel. I've been trying different things for using Swift. So for Swift, specifically what we're going to do for this patient is I was charging kind of like a Swift tip fee. And so I was charging $100, and plus I was charging for the cantharidin. I've kind of heard that might not be the best way of doing it, so I'm not doing that anymore. I'm just charging people for the Swift, which is $250, and not charging for the tip, but I've been kind of going back and forth. I tend to find, since I have one of the older versions of the Swift, it tends to be a little expensive for me to use it. And so that's why I was doing this tip fee, so I can do both tip and the cantharidin. So I'm kind of struggling with that. If you have any good ways that you do it, I'd love to hear what you're doing. But I'm doing cantharidin and the Swift. Next was an 84-year-old. This is a patient that Marjorie saw. Once again, she's seeing patients the same time I was, and she just did the callus and the nail care. So if you think about it, if she's writing a callus and getting $75, and then we're paying her $25 an hour, so it's going to easily pay for her to be a revenue producer. Next was a 65-year-old man, bilateral matrixectomy, and I did both edges for it. So he's going to come back in 3 weeks for a 10-minute slot. I also talked about the post-op kit, so all the patients get the post-op kit. Next was a 77-year-old female. This is a patient Marjorie saw as well for a right ingrown toenail and an IPK with lesion destruction. So IPK, I say, you have a wart, possible callus, and I do salicylic acid, so we're able to, she did the nails, and I did that lesion destruction for it. Next was a 64-year-old female, quick matrix follow-up in a 10-minute slot. Next was a 48-year-old that I did a pre-surgical discussion for bunions. And so this is the day that I'm doing a bunion on her in a couple weeks. I haven't come back within 30 days prior to go over the surgical consent and also to go over my pre-surgical discussion. So if you don't have those, you can go to patientpresentations.com. You can look at mine. And I've recently added a portion in there on how to improve healing. So if you want to look at that, it's including more regenerative medicine, and also my EBM products are in there that I'm recommending for patients. But so this is just an office visit, looking at the x-rays, doing the consents, and going over that presentation. The reason I do this is to reduce risk of litigation for patients. Next was a 72-year-old man. He had seen by Marjorie as well for routine. Another one was Marjorie. Next was a 65-year-old for right dorsal foot neuritis, number 5 out of 6. This is the only one right now that is being covered by Cigna. So Cigna is paying me $175 a treatment. It could be just because they cut everything in half, and so it's a temporary code. So I'm billing $350 and they're paying $175. So it could just be because they cut everything in 50%, but they are covering it, so we're going to continue doing it. Up to 6. Next was a 32-year-old female, right second med head, Shockwave, number 4 out of 6. Next was an 84-year-old man. Once again, this is a nail care patient, a new patient, saw by Marjorie. Also had a fissure to the heel, so I recommended for fissures I usually recommend super glue, and then the sleep socks, and then the urea skin cream. Those are all things that we have in the office. Next was a 75-year-old. This is a right matrix follow-up, and also had a new condition of bulbous Achilles tendonitis. This patient previously had Achilles tendonitis on the right. We did Shockwave. Not that problematic. I just recommended to go back to what they knew, the foam rolling, morning stretch, and things like that. If it doesn't get better, then I'll see her back for Shockwave. Next was a 66-year-old female for right hallux contusion. No fracture on x-rays. I advised it should get better in 3 or 4 weeks. If it doesn't, I kind of talked to them, or planted the seed, I like to call it, for Shockwave. Another patient was a 66-year-old man. Same thing with heel fissures. I find this time of the year, winter, they tend to get a lot of heel fissures. So we did the callus and recommended urea cream and the sleep socks. Next was an 81-year-old man for a matrix follow-up. Next was a 33-year-old man for bilateral IND, so ingrown toenail with infection. And the next one was a 77-year-old man, status post-matrixectomy, so doing well. So just a reminder, all these matrix follow-ups and stuff, they're all 10-minute slots, so they're kind of fit in with my schedule. The problem is I was seeing these patients and Marjorie's patients, so I'm going forward, I'm not going to be having those 10-minute slots on Tuesdays if I'm monitoring her nail care. The afternoon was a little bit lighter because she was not with me. She's only here in the morning because she does her own nail care patients. First was a bilateral arch pain and pronation with some left ankle pain. I did x-rays, and I did ultrasounds bilaterally, and I recommended doing Shockwave and orthotics for this patient. I just kind of planted the seed. She's going to try some other things. She wanted to try massage first. If they want to do that, a lot of times patients, they come in, and this is a good tip. So many times patients come in and they say, hey doc, can I try acupuncture? Can I try massage? Can I try physical therapy? Can I try all these other things? And I don't mind if people try. I just say, okay, you can try these, but I plant the seed. But if that doesn't work, then we're going to be doing Shockwave because I find that works very well. And we have to set a timeline that you're going to try this, because I think if people try, then they just never come back. So I tend to make a follow-up, like it's say in 2 months. So you can try that. How long do you want to try it? I want to try it for 2 months. So try it for 2 months. Then if it's not getting better, come back, and then we'll do the other things that I know that work. Next was a 25-year-old man. He had a right hallux IND. Next was a 72-year-old man. I did a nail sample. Reviewed the nail sample, sorry. It was, it was negative. And he also, we checked on Qutenza for him. So this was the first patient that I found that Medicare covered the Qutenza, but the secondary had a high copay. So it ended up being about, per patch, about $250. So the total would be $1,000. And so it was just prohibitively expensive for him to do that. So he wasn't able to do the Qutenza. So I did recommend him, and he was also seeing a spinal doctor for a possible spinal stimulator. The way I kind of explain it these days is I kind of explain it such as people sometimes have a for the heart, they have a pacemaker, kind of little thing they put to help stimulate the heart, to help it beat better. So I kind of explain this nerve stimulator in the back is kind of the same thing. It's something that you insert in there, and it helps stimulate to kind of calm down the nerve. So I think doing these comparisons help patients to understand this a little bit better. So using a heart monitor or a heart defibrillator as a way of explaining it for the spine. Next patient was a 61-year-old female with right hallux limitus. and left plantar fasciitis status post 6 shockwaves. Patient's doing better, and this is the one that did the orthotics, the only orthotics of the day. Next was a 69-year-old where I did x-rays. This patient had bilateral neuropathy, and this patient was referred from a physical therapist that came and visited us. So this patient, I recommended the new EBM neuropathy pill. The patient was status post right ankle fusion, so had a lot of subtalar joint arthritis, and I explained how the subtalar joint moved more. I did a cortisone injection. And I talked to him about doing Qutenza. So he was type 2 diabetic as well. And so I'm going to check on Qutenza coverage. So I'm going to see him back in 3 weeks for the cortisone follow-up. And then I'm going to see this patient as well once I hear about the Qutenza. Okay. And also he's going to be seeing Marjorie for nail care. Last patient of the day, this was a 51-year-old guy, very big guy. He had a pustular lesion to the arch of the foot. It looked like tinea-pedis. I did a biopsy in the past, and it didn't show athletes, but it still kind of looked like it. So I gave him ketoconazole, and he actually has orthotics, but the problem is, I don't know if it's due to his weight, but he's a big guy, and he has really painful metatarsal heads. And in his orthotics, originally, he wasn't having pain there, so I didn't add a metatarsal pad. So what I did is I added a large metatarsal pad inside that on top of that orthotic, and I gave him a medium as well in case the large one was too big. But I'm hoping that'll offload the forefoot region because he really doesn't have a lot of fat pad in all those forefoot regions. But the problem is it's all the met heads, and so I didn't feel comfortable talking to him about the Liposana, other type of treatment. Okay, so just so you guys know, we are starting to do this Liposana. We tried Leniva. Actually, we didn't really even try it and never really got around to trying it. But the Liposana, there are some patients, I think, that would be good candidates for it. The way I'm kind of explaining it is I'm explaining it as you can do Dr. Jill's pads on the outside, or if you want to, you can do Dr. Jill's pads on the inside, which is this Liposana, which is injecting fat into that area to help add more cushioning to the area. We are going to be charging $1,500, and it might need one or two, depending on how many met heads or the area that we're going to be injecting it for patients. And when doing this, what I'm finding more and more is this whole idea of selling the vacation. And this means like selling kind of what the patient could expect. And I think this is something that I'm forgetting when I'm seeing patients. So I saw a patient even today, and he was here for plantar fasciitis, a young guy, and I just went in right into the treatment. I didn't do that pause and say, hey, our goal is to get you back to how you were 9 months ago before you ever had this, and you wouldn't have to think about this. Wouldn't that be great? So having them imagine that, and then going forward, I think it's going to help reduce the resistance. But I find getting into that method of saying, what's this going to be like when you're better, or what it would be like if you had no pain, I think that we have to pause and do that, or I have to do that, because I think it's going to help case acceptance of recommendations go up versus run right into the treatments. I just think that little pause. So something that I'm working on, I just wanted to share. Once again, if you guys found this beneficial, I have a lot of resources on Podiatry Practice Mastery. You can download any of those resources, then you can also get on my emails. I try to send one email a week with helpful information from what we talk about. Once again, any questions, shoot me an email, don@podiatrypracticemastery.com. Thanks.